Our next speaker is Dr. Kristian Niemietz. Kristian is a senior research fellow at the IEA. In 2013, he completed a PhD in political economy at King's College London. Kristian previously worked as research fellow at the Berlin-based Institute for Free Enterprise and at King's College London, where he taught economics throughout his postgraduate studies. He's a regular contributor to various journals in the UK, Germany, and Switzerland. Over to you, Kristian.
Well, thank you, Grant. A couple of years ago, I was writing about pension reform, and back then, people asked me exactly the kind of questions that you see in this program. Which is the best system in the world? Can a free market provide in this area? Is there a system that comes close to a free market solution? And so forth. And back then, those questions were relatively easy to answer, because there are a lot of good examples around. I could always say, yes, of course there are. There's the Chilean system, there's the Australian system, there's a system in Hong Kong, there's a couple of other ones that are maybe not quite as good, but have some useful lessons. So it was relatively easy because there were enough real-world examples. In healthcare, that is a bit trickier. There is no obvious example. There is no obvious best system in the world. There's no obvious freest system in the world. It would be hard to actually define what that should even mean. What does that mean to have the best healthcare system in the world? So imagine you have a country or a health system which is doing superbly in treating complex stuff like cancer, but that is also doing poorly or mediocre in relatively simple things like accident and emergency care. And suppose right next door you had a system where it's exactly the other way around. Which of these is better? Well, it depends whether you ask a cancer patient or whether you ask somebody who has just had an accident. And that's always the problem with international rankings. It all depends a lot on what factors you include, what weight you attach to each. There's no obvious way of finding the best system in that regard. And the same applies to the idea, the question, which system comes closest to a free market solution? Because the problem is that in different countries, governments intervene in different ways, and it's hard to weigh them up against one another. So the American system is perhaps the most, the starkest example here. This is the system that most people believe is a free market system, although I guess Mike would not quite agree with that, but that's usually on the basis that on the financing side, about half of the funding comes from private sources, but then the government intervenes in other ways on the provider side. Or to use a less extreme example, in the Dutch system, you have a ban on for-profit hospitals. There's no for-profit hospital in the Netherlands. Whereas in the German system, which is otherwise similar, there's lots of for-profit private hospitals. That's a big sector. There are actually more for-profit private hospitals in Germany than in America, proportionately to population size. It's one of the biggest for-profit sectors in the world. So in that respect, it would seem that the German hospital sector is more liberal, closer to a market system than the Dutch one. But at the same time, in the Netherlands, those non-profit providers are relatively unregulated. So if you operate a hospital in the Netherlands, you're not allowed to make a profit, but otherwise the government leaves you alone. Whereas the government would not be able to interfere with your investment decisions and so on. Whereas in the German system, there is state hospital planning, and even the private ones are part of that. So which of these systems is freer? Well, hard to tell. It's not quite obvious. But nonetheless, I think on the whole, it's fair to say that the systems that I've just mentioned, the Dutch system, to a lesser extent the German system, also the Swiss system, these are relatively liberal systems. And I mean liberal in the European sense, liberal in the sense of being relatively government keeping its hands off. And I'd say if you picked the most liberal aspects of each of these systems, plus a couple of elements from elsewhere, you would end up with something quite close to a free market in healthcare. And it is worth saying that these systems, the Dutch, the Swiss, the German system, have some of the best outcomes in the world and across a wide range of measures, and according to a wide range of sources. And it's also worth pointing out that in these systems, you do have universal coverage. There's no uninsured population in either of these systems. So that is the aspect that people value most about the NHS, that everybody is covered, but that is also true in the systems that I'm talking about. It's impossible to go without healthcare in those systems, regardless of your ability to pay. So on those grounds, if that is your main goal, have universality, then you can make a reasonable case in favor of the NHS as opposed to the American system, but not as opposed to these so-called social health insurance systems, because that is something that is an outcome that they all have in common. Now, I'll get back to that in a minute, but let me say a few words about the theory about health economics more generally. People who oppose the use of market mechanisms in healthcare usually make the case that markets cannot work in healthcare because markets rely on a number of preconditions that you do not have in the health system. So above all, you need rational, well-informed consumers. Consumers who are easily able to judge the quality of different products, of different providers, and to make a well-informed and balanced judgment. That's the argument. And that is not the case in healthcare. That's not the way we make decisions in healthcare. So therefore, this argument goes that markets work pretty well in relatively simple areas. You can have a market for chocolate bars, you can have restaurants provided on the market, but not healthcare. When those conditions are not met, then a market cannot work. Well, there's a couple of problems with that. The main problem being that complexity is actually an issue regardless of how you organize the healthcare system. So the complexity problem, that does not go away if you nationalize provision. That's a problem that you don't just have in markets. That is also the case in a nationalized system. So here in the UK, if you go to a doctor and the doctor tells you there are 2 types of therapies that could work in your case, one is more effective, but is also a bit riskier, you have to make a choice, whether that's a well-informed choice or a not so well-informed one. That's completely irrespective of whether you have a market system, a nationalized system, or something in between, some combination. That is always the case. And the same if, say, a doctor tells you you need an operation, there's, let's say, 5 hospitals in this region that could offer that. You have to make a choice. Well, you get the same problem all over again, because NHS hospitals differ a lot in quality. They're not all the same just because they all have the NHS label on their front door. We see that in the rankings all the time, that there's massive differences in quality. The best ones do provide world-class healthcare, but the worst ones are more like Wild West medicine. There are the mid-Staffordshires at the lower end of the spectrum. So even in a nationalized system, you get variation, large variation in quality. You have to make a choice somehow, and it is going to be, in many cases, an imperfect choice. So I don't dispute the argument that healthcare is a lot more complex than chocolate bars and restaurants. I'm just saying that's not specifically an argument against market provision. Rather, that is something that is just part of the nature of the product that we're talking about here. And also, the argument cuts both ways. People who argue that markets would not work in healthcare because of all those information problems, strangely, also argue that the NHS is democratically accountable because it's controlled by us, the public. We are the public. well, but if we cannot make sensible individual decisions, can we really make sensible policy decisions then? Is that not the same problem? Because basically, what it means to nationalize a sector is that you replace individual choice with collective choice, with political choice. So if we had a national pub service, then the question of whether pubs should serve more real ale or more continental-style lagers would become a political question. You would then have one party saying we want more ale, and another party saying we want more lager. And rather than making that choice in your role as a consumer, you would make that choice at the ballot box while voting. But the choice doesn't become easier. Whatever bias you may have, whatever errors you may make, errors of judgment, you would still make those errors at the ballot box. So this idea that therefore we run the NHS collectively, even though we're unable to make sensible choices, this is a bit schizophrenic. If that is your main concern, information asymmetries, then you cannot at the same time argue that we as a whole, as a collective, as a team are running the NHS. And it actually turns out, if you look at this in a bit more detail, this whole democratic accountability argument, turns out this is mostly a bogus idea. I'm just writing a paper on that, and I'm looking at, among other things, what parties do in healthcare once they are in power, and what they said they would do in their election manifestos. And surprise, surprise, the overlap is almost zero. So whenever there's a big change in healthcare policy, it's usually born out of it comes out of some ad hoc basis. You cannot argue that it's driven by public demand, that we as a people collectively decide we want the healthcare system to be run in that way and not this way, and that then policy changes. So in reality, this is mostly a bogus idea, democratic accountability. And the second set of arguments that opponents of market mechanisms make is an ethical argument, that it is just morally wrong to make profits out of the misery, the sickness of other people. Well, that is a strange argument too, because even in a nationalized system, in the NHS, so you don't have profits as such. You don't have anything that an accountant would call a profit. But that doesn't mean that self-interest plays no role in health provision. The NHS is ultimately also run on the basis of self-interest. If you don't believe that, then let's stop paying the doctors for a while and see how many of them still turn up on the next day. There's an interesting book published by I think The Spectator, which contains a series of interviews with 10 different health secretaries, going back all the way to the 1980s. And these are people who disagree on almost everything. They have completely different ideas about how the health service should be run, but they all agree that being health secretary was the toughest job that they ever had, because they describe it as a constant battle against lots of different interest groups within the health service. So the NHS is actually a hotbed of rent-seeking. All these different health secretaries say afterwards, whatever you do, whatever idea you come up with, somebody will, some interest group will be negatively affected, and they will try to throw a spanner in your works. So the idea that in the NHS, since it is a nationalized service, that therefore everything is based on altruism and the ethics of caring and compassion, that is pretty much the Walt Disney version of what really happens. That is not the way that the people actually running the service perceive it. So just to give you one example that I happen to remember, at one point, don't remember when, there was a proposal of giving more autonomy to nurses for routine procedures that don't need a doctor present. Sounds like an eminently sensible idea, because it would mean that the nurses can concentrate on the routine procedures, and that frees time for the doctors to concentrate on the more serious stuff. Nonetheless, a lot of doctors were opposed to that. Why? Because they felt that this would undermine their status if the nurse can suddenly do a lot of things that they normally do. And it meant a loss of power, that they no longer had to sign off everything. And this is the sort of stuff that you get even in a nationalized system. So I mean, there are some serious economic arguments about markets in healthcare. I'm not proposing a 100% pure market solution, but I would be very careful with these romantic ideals about the NHS being built on an ethic of compassion. It is actually a system in which you get rent-seeking as you would expect in a nationalized industry. So what could be the alternative? If it's not the NHS, what could work? Well, as I said, there are the relatively liberal continental insurance systems. You could combine the most liberal aspects of all of those. In particular, what the state would still do in a system like that is it would guarantee universality. That is pretty much what I would like to see the role of the state being limited to. So you would have the state guaranteeing that everybody has access. In the continental system, that happens in two ways. Firstly, there's a straightforward demand-side subsidy. If you cannot pay for your health insurance, the government pays your premium for you on a sliding scale. So therefore, money is never an issue. And secondly, if you are a health insurer and you have lots of people on your register with complex chronic conditions, then you will get a compensation payment to compensate you for those extra costs that you incur. And those compensation payments are ultimately paid by insurers who have a disproportionate number of healthy people. What it means is simply that you don't get cherry picking. You make cherry picking economically irrational. You incentivize insurers to take on people in poor health, and you make sure that even if an insurer cherry picks, they would still have to pay for the non-cherries. They would still have to pay their share of the higher costs of other people. And that means you have a level playing field between different insurers. It doesn't matter whether you have only 20-year-old people who go to the gym all the time, or whether you have lots of elderly people with complex chronic conditions. You can compete on a level playing field. That is what this risk structure equalization is all about. Essentially, what you do in systems like that is you acknowledge that there are some problems with market provision, but what you do then is you intervene specifically in those areas where the problems arise. So intervention in those systems is more like keyhole surgery. You have limited, targeted intervention rather than a wholesale government takeover, which is more like a sledgehammer approach. You intervene in specific areas, and otherwise you leave the market untouched. And the result of that is that you get a situation in which the problems with market provision are overcome, and you still get all the benefits of a functioning market, which are that you get the market discovery process, you have a trial and error process, people doing things in different ways, finding out what works. You get free choice, you get consumer sovereignty, you get competition. And ultimately, this is what this session is really about. Do you want a system in which providers have to compete for you, in which providers depend on you, on your choices as individual patients for their economic survival? Or do you want a system in which providers are accountable to politicians and bureaucrats? Do you trust politicians and bureaucrats to run the system well on your behalf? Well, I think it's a no-brainer. Thank you.